Alrighty, good morning everyone. Welcome to our third Paramedic Rounds presentation via webinar on CPAP. My name is Stephanie Romano and I'm one of the regional paramedic educators with Base Hospital, and I'll be running through most of the behind the scenes aspects of this webinar. So if you haven't joined us yet for a webinar, the way it works is that you'll see a PowerPoint presentation as well as you'll hear our presenters discuss the material at the same time. So during the presentation there'll be three multiple choice questions that will pop up so that we can sort of test your knowledge before we actually go through the material. And I'll kind of walk you guys through those questions as they come up. So at the end of the presentation, I'll then open up the discussion to the rest of you so that anyone can ask questions or make any comments. Keep in mind, though, that if you choose to ask any questions at the end of the presentation, you'll need a microphone and that everyone else will be able to hear your questions. If you don't happen to have a mic or would prefer to ask a question anonymously, then feel free to type your question in the text box, and then we'll answer those questions as we go through the presentation. And feel free to do that at any time during the presentation. So that pretty well covers the administrative side of this webinar process. So let me introduce you to our team of presenters. We have Morgan Hillier here, who's a medical student at Western, and will be part of the graduating class of 2011. We also have your Regional Medical Director, Dr. Mike Llewell, and one of our local medical directors, Dr. Adam Duclo, who will also be presenting with Morgan. With that, here is your webinar on CPAP.
Hi, good morning, everyone. My name is Morgan. Thanks a lot for joining us this morning, and thanks to Dr. Duclo and Dr. Llewell for being here to help out with this. So as with all seminars, we'll start with some objectives just to get a sense of what we're going to go through today. So firstly, we'll outline the evidence for pre-hospital CPAP, which is fairly new and up and coming. As well, we'll talk about normal pulmonary anatomy and physiology, which will help give us a sense of the abnormal or deranged pulmonary anatomy and physiology that we see in a lot of our pre-hospital patients. We'll describe some of the mechanisms of action of CPAP and its use in the pre-hospital setting. We'll talk about and review the indications, conditions, and contraindications for pre-hospital use. And then finally, we'll talk about an approach to monitoring our patients after we've applied CPAP and possible complications and pitfalls associated with that. So why CPAP in EMS? So there's quite a bit of literature looking at the use of CPAP in the hospital setting, specifically in the intensive care unit as well as in the emergency department. However, it's, as we said, a fairly new and upcoming entity within the pre-hospital setting. So one of the initial papers, which was an observational study by Hubble et al. in 2006, looked at a CPAP protocol where they compared two different EMS systems, one of which was using CPAP and one of which was not. And they did see actually from the out of hospital, the pre-hospital interventions, that there was a decreased intubation rate in hospital, decreased mortality, and as well for patients a decreased hospital stay. After that study, one of the other big ones was Thompson et al. in 2008, who did a randomized control trial and looked again at patients who received pre-hospital CPAP and those who didn't. And again, he and his team were able to show decreased intubations and decreased mortality from the application of CPAP in the pre-hospital setting. And important to note here as well, no harm from using CPAP in the pre-hospital setting was noted with these interventions.
Morgan, it's Adam here. Maybe you can touch on why a randomized controlled trial is so important.
Sure, absolutely. So within the research realm, randomized controlled trials are really our gold standard for research. So a lot of the research that we do, we look retrospectively, so we look back on charts and try to make associations between an intervention that we do and a result. But of course, these are just associations. So ultimately what we need to do is randomized controlled trials. So prospectively, so ahead of time, we will choose an intervention and randomly assign some patients to receive it and some patients to receive regular care, what we would normally be doing, and that way there's no bias involved in it, and we go through the intervention, and after having enough patients to see an effect, we're able to look at whether the intervention made a positive effect on these patients. So in the study by Thompson, what they actually did is assigned certain ambulances to have CPAP and certain ambulances not to, and then over time we're able to look at differences between the patients who received the CPAP and those who didn't. So we'll move on and talk just quickly about normal anatomy and physiology. Of course, this is a review for everyone, but the architecture of the lungs is basically similar to an inverted tree-like structure. And the reason this is important is as our airways get smaller and smaller and branch out, the amount of cartilage, so the cartilaginous rings, decrease, and this leads to the airways being much more pliable and therefore prone to collapse. Now, this is a good thing in the distal airways because it allows for them to distend and for gas to fill the alveoli. But of course, the concern here is that these airways can then easily collapse and lose their patency, and that's going to be one of the important points to make with CPAP. So we'll move on to the next slide there. So talking about the alveoli specifically, the alveoli are our functional unit of respiration. So that's where the gas exchange is going to occur. Whether we're ventilating our dead space, our trachea and bronchus or not, is not going to make a difference as far as respiration, the actual movement of gas in and out of the blood. So it's really important that we're ventilating down into the functional units of respiration, into the alveoli. And there are a few things in the regular healthy person that assist with that. So one you may have heard of before is surfactant, which is a very important liquid in the alveoli. In technical terms, it decreases surface tension, but really in practical terms, the way to think of it is sort of a lubricant that prevents alveoli from sticking together. So in the normal healthy person, we have surfactant, which maintains our alveolar patency and allows us to respire properly. We'll talk a little later about why this can be a problem with our patients with respiratory pathology. And of course, as a reminder, alveolar collapse is going to lead to decreased lung volume, and when that occurs, there will be decreased blood oxygen, which is hypoxemia, and also an inability to expire CO2, which leads to hypercarbia or hypercapnia. Increased CO2 in the blood. The final point I'll make as far as our respiration is with our respiratory system, the muscles of respiration, which of course are very important. So firstly is our diaphragm, and our diaphragm is at the bottom there in red, of course. So as the diaphragm contracts, it flattens and we get a negative intrathoracic pressure. This of course is going to suck air in through the mouth and hopefully all the way down to the terminal bronchioles and into the alveoli. So that negative pressure really helps to maintain alveolar patency, keep the alveoli open along with the surfactant. Now the intercostal muscles, so the muscles within our rib cage, are also involved, and they help with chest excursion, so outward movement of the chest. And it's our diaphragm and our intercostal muscles that are going to allow for inspiration. And in the regular healthy person at rest, exhalation is actually a passive process. So the elastic recoil basically of the lungs and the chest wall is going to allow for expiration. This is important because respiration, the act of ventilating our body can use quite a bit of energy and oxygen. So therefore we want this to be as efficient a process as possible. That being said, I'll turn things over to Stephanie here with our first poll question. Just want to get a sense of what people think here. So go ahead, Stephanie.
All right, guys, so you should be able to see your first poll question up on your screen. And it has to do with the amount or the percentage of respiratory function that you're using in acute respiratory distress. So take a few seconds, read that question, and give your answer, and I'll close it in a couple seconds here.
And again, so if anyone's unclear, what we're really asking is what percentage of the oxygen that you inspire is going to go directly to fueling your respiratory effort.
So you should be able to see your poll results there. 40% of you said 20% use, and 60% of you said 40% use.
Good. Okay. So the correct answer, I guess I'm supposed to give that now, eh? So the correct answer is 20% of your respiratory function. So let me explain that a little more clearly and why that's important for us. So in respiratory distress, of course, accessory muscles such as the sternocleidomastoids and the scalenes, and we'll show a picture of those in a moment, become involved and help to increase chest excursion. Inspiration and expiration become an active process. So as you can imagine, this is going to increase the amount of work that a person has to do just to maintain their ventilation. So to give an idea of the numbers, at rest a healthy person uses about 4% of the oxygen that they inspire to fuel the muscles of respiration. So of course it takes some of that energy to keep us breathing. What is of concern is that in acute respiratory emergencies, you may use up to 20% of your oxygen simply to fuel respiratory effort. So you can see how this can become a downward spiral for a patient who is in respiratory distress. As they become hypoxic or hypoxemic, they're requiring more oxygen, they're working harder to breathe, and then their oxygen demand, just by virtue of breathing harder, is going to go up. So this, I hope, can really illustrate why someone can get into trouble and actually go into respiratory failure when their work of breathing just becomes too high for them to maintain. And we'll show you quickly here. It's one of my Google images. Have a few examples of the accessory muscles. So as a reminder, the sternocleidomastoid in the front there, scalenes on the side which attach to your upper ribs, and then the trapezius muscles there. So all of these become involved, and as I'm sure you've seen with your patients with respiratory distress, you actually start to see active contraction and use of these accessory muscles. So we'll move on to pathophysiology. So there are a few common conditions leading to respiratory distress that we see in the pre-hospital environment. The first two we'll focus on a little bit more. So the first is cardiogenic pulmonary edema. Talk about that. We'll talk about chronic obstructive pulmonary disease, of course, and we'll also touch on asthma and pneumonia as two of the other main causes for respiratory distress. So firstly, cardiogenic pulmonary edema. So patients who develop flash pulmonary edema, generally this is secondary to congestive heart failure. So these are patients with poor heart function, specifically with left ventricular failure. So as we recall, blood after being oxygenated into the lungs moves through the pulmonary veins over to the left side of the heart. And if the left side has failed and isn't pumping well, then we have backward pressure into the lungs. So we develop vascular congestion, and this increases the hydrostatic pressure, so sort of the fluid pressure in the lungs, and causes leakage of fluid into the alveoli. And obviously with fluid in the alveoli, this is going to reduce gas exchange and lead to hypoxia. And an important other component is you can actually have a washout effect of the surfactant in the lungs from the pulmonary edema, and this is going to lead to atelectasis. So bottom line with congestive heart failure and pulmonary edema is that we lose effective lung volume and therefore lose the ability to exchange gas effectively. And just as a quick picture here, so again, decreased gas exchanges due to fluid buildup and alveolar collapse. So acute pulmonary edema. So as far as our patient presentation, basically what we'll see is a patient who's short of breath with increased work of breathing, so that accessory muscle use and tachypnea or a fast respiratory rate. Also, you'll note diffuse inspiratory crackles in all lung fields. So this is a diffuse process. Of course, at the bases of both lungs, you may also have some collapse and therefore decreased air entry. But the main clinical feature is going to be the bilateral diffuse crackles. Something to look for as well in our patients is a history of coronary artery disease. So often with cardiogenic pulmonary edema, these are cardiac patients. So they're patients with a history of hypertension, diabetes, high cholesterol, family cardiac history, and they may have a long-standing history of acute myocardial infarctions or heart failure. And again, it's important to highlight it really is all in the history. So our medical history from the patient and from the patient's friends and family on scene is really what's going to paint the picture for us initially of what the clinical situation is. So the other thing I should mention is sort of the presentation with our vital signs. So our patient with acute pulmonary edema, what you'll really see is a tachycardia associated with diaphoresis. The patient will be tachypnic, so they'll have an increased respiratory rate. These patients are also often hypertensive, and then with our O2 saturation, they're often hypoxic. And just to also talk about COPD, there are a few differences in these patients' presentations. So quickly, COPD is our chronic airway disease. Usually you'll elicit this on history as it is a chronic situation, and is often due to cigarette exposure, potentially workplace chemical exposures, though occasionally it can be due to genetic predisposition. Basically, COPD is a combination of both bronchitis and emphysema. So bronchitis is our chronic inflammation with scarring and mucus production. And I'll show a picture of that in a moment. And emphysema is disease in the lung parenchyma, so in the alveolar tissue. It's characterized by loss of elasticity of the lung parenchyma, so that alveolar tissue, as well as destruction of alveoli. And show a quick picture here. So again, up at the top there with our chronic bronchitis, it's airway inflammation and scarring in the bronchi, so the terminal bronchi leading to the alveoli. And down at the bottom with emphysema, you see dilation and destruction of the air spaces, and again, therefore, decrease in effective lung volume. So we've all heard the term COPD exacerbations before, so I'll just touch on that quickly because that is often in the EMS setting what we are called for. So these are usually precipitated by a respiratory infection, though there are a few other causes. And basically what you'll see is a patient who becomes acutely short of breath. They have increased work of breathing again, and it's also characterized by excessive secretions. So this is usually a clear, productive cough with quite a bit of increase in their secretions. And this, again, with our other respiratory conditions, can potentially lead to respiratory failure. There are a few other causes of a precipitation of COPD. So respiratory viruses and bacteria are one, but often another cause will be patient compliance with medications. So patients who are not effectively using their puffers. So that's something also to elicit on your history. As far as our presentation, sorry, I will mention quickly with COPD, along with our increase in work of breathing, again, looking at our vital signs, they will be similar to our patient in pulmonary edema. Tachycardic patients, sometimes diaphoretic, most certainly tachypnic, increased in respiratory rate, and potentially hypoxic. Along with this, on respiratory exam, you'll often hear the classic expiratory wheeze that we hear in our COPD patients. I'll touch quickly on asthma. Asthma, as we know, is a bronchospasm. This is secondary generally to irritants or to an allergic stimulus and affects the small airways. So basically right above the alveoli and the terminal bronchioles, you'll have this bronchospasm, and because of this, patients are generally able to inspire to get air into the alveoli, and it then becomes trapped, and they have a lot of trouble expiring that air. So this is what leads to the expiratory wheeze that we hear with our asthma patients. And the concern here is as patients continue to breathe in and air trap, they have decreased ability to expire and actually ventilate. It is worth mentioning, of course, that this expiratory wheeze can lead to, this expiratory wheeze can lead as well to an inspiratory wheeze and eventually to the silent chest where we're not moving any air at all. As far as our presentation of our asthma patient, again, the history is a key component. So these are patients who are diagnosed with asthma. They often have a recognized inciting event or their trigger, exercise, cigarette smoke, or other environmental triggers that set off their attack. And our primary treatment, as we know, is bronchodilators. It's our Ventolin and our 100% oxygen for these patients. Finally, I'll touch quickly on pneumonia. So pneumonia is a bacterial, viral, or fungal infection of the lungs, and generally it's focal. So in most patients, this will be in one lobe of the lung. So have an X-ray up here, and you can see basically right in the right middle lobe there, quite a large white area, which is a pneumonia. And the reason this is important for us is these patients will often present with more of a focal pattern, so crackles in one area of their lung field rather than bilaterally and diffusely. Along with other infections, these patients generally present with a fever. They may have a productive cough, and again, this is the mucopurulent cough that you'll see, so the yellow or the green sputum. And they may also complain of localized chest pain in the area of the pneumonia. So we have our sort of a brief review of the common pathophysiologic problems that may cause acute respiratory distress. And now I'd like to introduce CPAP. So CPAP basically is one of our methods of non-invasive positive pressure ventilation. So CPAP, or continuous positive airway pressure, is this device that this gentleman on the screen is wearing. Basically it hooks up to an oxygen source and provides a constant level of positive airway pressure. In contrast to that, BiPAP, or bi-level of positive airway pressure, is a bit of a more complex device that you will see in the hospital. And this device has the ability to change pressures based on whether the patient is inspiring or expiring. So as the patient breathes in, the pressure will increase from this machine to help support their breathing. As they breathe out, it will decrease, but still maintain a level of positive expiratory pressure on this patient. Sure. I think Mike is Dr. Wells. Go ahead.
Yeah. Morgan, on this slide we have the Buzniak device pictured, but I wanted to make the point that throughout the region we have different devices, and it's not necessarily specific to just the Buzniak. I know that Lambton County has a different device than this, so not everyone has to carry the Buzniak. A key difference I like to talk about when it comes to CPAP versus BiPAP is I always say CPAP's a lot like driving down the 401 and sticking your head out the window. It's a continuous level of air that's hitting your face, whereas BiPAP is exactly when you stick your head out the window, but then every once in a while you turn your head to the side and you're able to exhale without the same sort of positive pressure in. I think it makes it a bit easier to understand how the positive pressure ventilations that come with CPAP and BiPAP happen.
Great. Okay, thanks, Dr. Well. So we'll talk quickly about how CPAP works. Actually, that's a good segue into it. So as you saw, we have a tight-fitting mask for our CPAP device, whichever device that may be. And we require high flow oxygen, of course, to this device. And the devices have a flow restriction on the exhalation port, which exerts a positive pressure of the airways. And as Dr. Luell said, this is constant. So this is both during inspiration and in expiration. So that being said, what are the main effects of CPAP? What's sort of the mechanism of action? So firstly, the positive airway pressure is going to splint the airways open. So as we mentioned early in the presentation, the terminal bronchi and alveoli have a tendency to collapse because of the lack of cartilage. And you can think of this positive expiratory pressure and constant pressure as just helping to push them open and maintain alveolar patency even during expiration. We can also look at the positive pressure decreasing the amount of leakage of fluid into the alveoli. So as our hydrostatic pressure increases, we can counteract that pressure by increasing the pressure within the alveoli with CPAP. One of the big effects, one of the advantages with CPAP is the positive pressure will actually decrease your work of breathing and your oxygen requirements. So we talked about these patients requiring up to 20% of their oxygen just to maintain their breathing. So if we can provide some support for them, we can make them a lot more comfortable and decrease the amount of work required for them to breathe. Finally, a quick point, actually we can have some improvement in cardiac function with CPAP as well. By increasing the intrathoracic pressure, we can actually change the preload and afterload on the heart, and for patients in heart failure this can be beneficial for them as well, but we won't get into all the specific mechanisms there. So with our cardiogenic pulmonary edema patients, again, just to reiterate, with our picture here, it's the decrease in the leakage of fluid into the lungs from the hydrostatic pressure that is a real advantage here with our CPAP device. Splinting airways again, so maintaining alveolar patency because of our decrease in surfactant and our increase in alveolar collapse, our decreased work of breathing, and hopefully a decrease in atelectasis, so forcing open some of those airways that have collapsed. With COPD, again, splinting our airways open, maintaining patency, decreasing atelectasis, and very important in our COPD exacerbations is decreasing the work of breathing and the oxygen requirements for these patients. So another quick poll question here.
All right, guys, so again, you should be able to see your question up on your screen. This one relates to the differences in how CPAP works for COPD versus acute pulmonary edema. So I'll give you a couple seconds just to answer this one. Just a couple more seconds. Seems like most of you are almost done. Okay, and here are your results. It seems like 29% of you picked work of breathing, 29% picked atelectasis, and 42% picked hydrostatic effect.
Okay, so the correct answer, though all three are very important, the correct answer is the hydrostatic effect there. So with our congestive heart failure patients, the increase in hydrostatic pressure in the pulmonary circulation is leading to the pulmonary edema. So with those patients specifically, we're using our CPAP, our positive pressure, to decrease that hydrostatic effect and decrease the amount of leakage of fluid into the alveoli. Good. So just getting to the end here. So with our asthma patients, just want to make the important point that CPAP is contraindicated, and there are a few reasons that is. We discussed earlier with our bronchoconstriction, the main concern with asthma there is air trapping and hyperinflation of the lungs. So you can imagine the patient takes a breath in, they're able to inspire, and then on expiration the bronchi really collapse down and the gas stays in the alveoli. So the concern is that then if we increase their positive pressure, we allow them to breathe in an even greater volume of air, of gas, but again that hyperinflation and that air trapping remains, and we can actually do harm, the serious concern being something like a pneumothorax. So the real focus with asthma is on our bronchodilators and our 100% oxygen through our face mask or through our nebulized salbutamol. And finally, with pneumonia, again, CPAP is contraindicated. And the main reason here that CPAP is contraindicated is the evidence is really unclear of its benefit. And there are concerns about increasing positive pressure and preventing patients from being able to clear their secretions, which are in fact generally bacterial in nature. So with our pneumonia, CPAP is contraindicated. So our patients who are febrile with a new onset of cough and other symptoms of infection, the focus is on 100% oxygen and having them assessed rather than support with CPAP. So we'll go over, of course, our indications, conditions, and our contraindications here. So, yeah, go ahead.
It's Mike Alveoli again. I wanted to
Sure.
sort of touch on the pneumonia issue. You're absolutely right that the pneumonia itself is contraindicated by the directive, but it also speaks to the underlying pathophysiology of the disease. People that are in respiratory failure from pneumonia, they're going to have a long, this is not something that's going to get better overnight, whereas pulmonary edema with aggressive diuresis, you can temporize with CPAP or BiPAP and turn them around within 12 to 24 hours, whereas if you're in respiratory failure from pneumonia, you're more likely looking at a long-term ventilation, which requires deep suctioning and a better care of the actual secretions that they're manufacturing, and that may take over weeks. So we're not able to reverse this as readily as we can with a COPD exacerbation or CHF.
Okay, great. Thanks, Dr. Llewellyn. So we'll, of course, go over our indications, our conditions, and our contraindications for CPAP. So as within our directives, the patient must be awake and able to follow commands. This will be very important. So they also need to meet 2 of the 3 criteria. So they must be tachypnic, so respiratory rate greater than 24%. As far as their oxygen saturation, less than 90%, and accessory muscle use. So 2 of those 3. And then finally, they have to have signs or symptoms that are consistent with an exacerbation of COPD or with acute pulmonary edema. Our condition is age 12 for our CPAP or a weight of 40 kilograms. And then finally, our contraindications, I've sort of tried to organize in a way that's easy to remember. So one is if their respiratory distress is due to another medical condition. So that would be things such as asthma or pneumonia. And again, our history is very important. History from the patient is very important to determine this. Number 2 is conditions that may be worsened by CPAP. So there are a few specific things we need to look for where we're concerned because of what the physiologic effects of CPAP may be. So a pneumothorax, for instance. The last thing we want to do with pneumothorax is introduce positive airway pressure to that patient, as you can actually convert them to a tension pneumothorax. Secondly, a systolic blood pressure of less than 90 is a concern, and we talked briefly before about decreasing preload in the heart. And the concern here is by increasing your intrathoracic pressure, we can decrease the amount of blood flow returning to the heart. And if we have someone who is hypotensive and we decrease the volume to their heart, we can really bottom out their blood pressure. So we have to be very careful with systolic blood pressures and monitoring for effect. And 3 is major trauma or burns. So trauma with to the face, neck, chest, or abdomen, CPAP would be contraindicated. And then the final sort of block of contraindications is when another intervention is required or would be preferable. So if our patient's unable to cooperate, if they have a decreased mentation, or if they have an inability to sit upright, CPAP is going to be very difficult to use, and we need to be thinking about other interventions such as bag mask ventilation. If our patient is unable to maintain their airway, then certainly CPAP is contraindicated, as it does not secure patency of an airway in any way. If your patient is intubated, of course CPAP is not appropriate. If they have facial abnormalities that make the CPAP unable to fit on their face, or finally if they have a tracheostomy, of course CPAP would not be effective. With respiratory rates of less than 8, CPAP is contraindicated, and that is, of course, because though this is positive airway pressure, it relies on the patient's own respiratory effort. So your patient with a respiratory rate of 4 is going to have 4 well-supported CPAP breaths, but of course that's not an adequate amount of ventilation for them in a minute. And then finally, of course, if someone's in cardiac arrest, we have other interventions that we need to execute. So after we've recognized a COPD exacerbation or a CHF with pulmonary edema, we've applied our CPAP, and we need to assess for the effects of our treatment, as we do with any intervention in the pre-hospital setting. So what are we going to assess for? We should see a decrease in the respiratory rate of these patients, and along with that, hopefully an increase in their SpO2, their blood oxygen saturation. Ideally, we'll also see a subjective improvement in their dyspnea and a decrease in anxiety associated with decreased breathing. And it's important to note here that patients, of course, who are in respiratory distress are not simply going to accept a mask, tight-fitting mask on their face without some coaching. So there is going to be a period of time where you need to explain this device, apply the device, and really actively coach these patients to help get their respiratory rate down and allow the CPAP to support their ventilation. With our patient monitoring, this is not an intervention where we can apply it and then actively work on something else like our ACR or other interventions. It really requires eyes on the patient and eyes on the monitor during your CPAP intervention. So vital signs Q 5 minutes. So every 5 minutes, and particular attention to blood pressure, to make sure we're not dropping their blood pressure below 90, and then also watching the patient for adequacy of ventilation, because again, though this will support their respirations, patients may still go into respiratory failure and require active bag mask ventilation. So we really need to have eyes on the patient and eyes on the monitor during this intervention. Finally, with our patient monitoring, airway is very important. As we have a tight-fitting mask, anyone with a great deal of secretions or vomiting can potentially obstruct. So we have to keep a vigilant eye on the airway. Lastly, I'll just mention complications quickly of using CPAP. So again, we talked about hypotension, so blood pressure less than 90 being a contraindication. We do have to watch for that. Watching for conversion of a pneumothorax into a tension pneumothorax, that would be a very serious complication. I mentioned airway obstruction, so watching our mask and watching for secretions or emesis that may obstruct a patient's airway. We have to remember that CPAP requires continuous oxygen supply, so we have to watch our oxygen source, and we have to remember that CPAP relies on patient's respiratory rate and is simply a support device. A number of patients may have an intolerance to the face mask, so again we talk about coaching our patients, and some, however, will not accept CPAP or accept that intervention. And finally, vital signs Q 5 minutes. We need this constant monitoring of our patients to make sure these complications are noted and dealt with. So I'll pass it over to Stephanie again for our final poll question.
All right, just a quick and easy poll here, guys, just to see who has actually gone through their CPAP certification training through our base hospital. Most of our services do have CPAP now, and if they don't yet, it's likely coming in the near future. Just a quick little poll here. Great, and it looks like almost 80% of you have had training with base hospital, so fantastic. So that pretty much closes the end of the lecture portion of this webinar. Big thank you to Morgan for going through that. So what we can do now is actually open up discussion to the rest of you who perhaps have any questions.
It's Mike here.
Yeah, absolutely. Go ahead, Mike.
We had an excellent question come off the internet here from one of the medics asking about at what point during the call should I begin the CPAP? And that's a frequent question we get with regard to any directive. At what point do we actually begin a specific directive? And quite honestly, from the base hospital point of view, when it comes to directives, we don't want to be so prescriptive as to tell you how your actual call should play out line by line, because you're the expert in the field, you're there sitting there, and it's a very dynamic and fluid situation. Quite honestly, with CPAP, if you walk in the door and you see someone who's extremely short of breath and qualifies and meets the indications for CPAP, then I would suggest that as soon as you rule out that there's no contraindications, you can begin applying the CPAP, or because it takes a bit of time to actually get it out, get it set up, while you're for the second paramedic is treating the patient's underlying conditions according to the appropriate treatment protocol. And that itself is actually one of the notes on procedure 1 on the second page of the CPAP directive. So the flow of a call, it's going to be different with every single paramedic, as it is with every different physician. We do things differently in a different order. So as soon as you possibly rule out the contraindications, feel free to apply the CPAP.
Great, thanks, Mike. So right now we can actually open this up to the rest of the medics that are watching and listening. So if you have a question and you have a microphone and would like to share that question, you should have a hand icon on the right side of your toolbar or your taskbar. So if you can, that just lets me know that you've raised a hand and have a question, and I can see that, and I can unmute you, and then you can actually ask that question to the panel of presenters here. So if anyone has a question, feel free to go ahead and click on that hand. Otherwise, if you don't have a mic, or if you don't want to be verbal to everyone who's listening, you can actually still type your question in the question box, and we can go ahead and answer it that way as well. We'll just give everyone just a couple seconds here, see if anyone has any other questions. Bill, looks like you have a question, so I will unmute you. Yeah, Bill, go ahead.
Oh, hi, Bill here. Can you hear me?
Yeah, we can, Bill. Go ahead.
Okay, I just want to know how long a person can be on CPAP. I mean, we can do it through the duration of the call, but does it continue on after to the hospital as well, or do they take them off at the hospital? I just wasn't sure about that.
If this is Adam Duclos here. If the emergency physician that's seeing the patient feels that the CPAP was indicated as the directive was applied, they will likely continue the patient on BiPAP. And there's a variety of reasons that the hospital will tend to use BiPAP as a form of ventilation. The practicality of providing BiPAP in the field would be very difficult. If you've seen a BiPAP machine in the emerge, it's a fairly large machine that's actually the size or bigger than a ventilator. Hence the reason that CPAP is usually used pre-hospital. It's small, it's light, there's disposable products, all those sort of things that you need to have in the pre-hospital field. And how long will you continue that BiPAP for? It's anywhere from half an hour to 24 hours sometimes. In general, it's a respiratory strategy that is thought to be best utilized for less than 4 to 8 hours, but there are people that are on it for 1 and 2 days at a time on the respirology ward in the hospital.
Okay, thank you.
Does that answer your question?
Yeah, partially. I just wondered, as a pre-hospital care worker, how long could we have that patient on CPAP? Because say we had a run that was like a half an hour long. I mean, would that hinder or hurt the patient? I know it's based on the vital signs. That's what I was concerned about. Long distance. I
would continue for your entire transport as long as they continue to meet the directive. And there's reasons in the directive for when you stop.
Stop, yeah. Understood. Okay, thank you.
There's also been a couple people have asked about differentiating between CHF and pneumonia on the text questions. And as with any medical diagnosis, it's a constellation of signs and symptoms that you're looking at to help you determine the most likely diagnosis. One of the medics asked specifically about differentiating between bilateral pneumonia and CHF. It's difficult, but in that scenario, you're looking at the person with pneumonia is more likely going to have a fever. Their sputum is more likely going to be green and thicker, whereas the person with CHF is more likely to have the whiter, clear, frothy sputum, have other signs of edema, so peripheral edema, an elevated jugular venous pressure if you're able to assess that, and a cardiac history. You are not going to be right 100% of the time, as doctors and physicians aren't right 100% of the time, that's for sure. So, but those are the things you'll look at to try and differentiate between the two disease processes.
I think it's important also, Adam, it's Michael well here, to note that many times you'll be transporting these patients and they may not improve on CPAP. And if you come transporting into a smaller hospital, that smaller hospital may not actually have BiPAP as well. But in that situation, certainly the emergency physician that's there always has the option to intubate these patients. Some of your patients aren't going to improve with CPAP, be it from pneumonia, be it from CHF, realizing that pneumonia is a contraindication, but we may have missed that in the field. And if it is, it's not a big deal. But we can always back up and intubate the patient and then transfer them off to an ICU. So we always have that option in our back pocket.
Great, thanks guys. I think we have another hand up from Ivana. So Ivana, I'll go ahead and unmute you. Go ahead and ask your question.
Hi, I was just wondering the difference in patient outcome between BiPAP and CPAP, and also if at any point we will be getting BiPAP on the trucks. I'm not sure if that's an option or not.
That's an excellent question, actually. BiPAP was around, the first studies looking at BiPAP started coming out in the mid to late 90s, and quite powerful in terms of their studies, showing you can really avoid intubation. I don't think from the feasibility point of view, BiPAP's actually been studied pre-hospital, largely, as Adam was mentioning, just the simple fact that it's such a cumbersome unit to actually move into the pre-hospital environment. It's not like your Bujniak or your other commercial products like the Portavent, which are actually portable and smaller. So I don't think we'll ever see BiPAP move to the pre-hospital environment. I don't think I'm not aware of any study that actually compares CPAP to BiPAP head-to-head in the pre-hospital environment as well.
Okay. Thank you.
Great. Does anyone else have any questions? I don't see any other hands up. Let's give everyone a couple more seconds to see if any other hands come up. All right, any other comments from Dr. Lual or Dr. Duclos?
There's a question that just popped up here. I believe it says, will the CPAP protocol take precedence over nitro for pulmonary edema, or will one treatment be determined to be used over the other, and is Lasix not to be used at all in these patients? So an excellent question is how to best manage pulmonary edema. Certainly, we've discussed this as a program on a couple occasions about pulmonary edema. When do we decide to use nitroglycerin? When should we keep them on the CPAP? In my mind, the CPAP is the more powerful therapy than nitroglycerin. So if you are having a patient that you applied CPAP to and they are improving with CPAP, then I see at this point you have the option to maintain them on the CPAP if they're continuing to improve. You always have the option, however, as it says in the directive, to remove the CPAP mask and administer nitroglycerin should you feel that they meet the indications for that directive as well. My thinking is that, and our thinking as we've discussed this, is if you're improving on the CPAP, there's no necessary reason to have to pull them off, just especially if they're improving. The second issue that came up in the second question was Lasix. Well, Lasix is one of those medications that, quite honestly, is more historical. You're going to see it doesn't really actually have a directive on the next round of directives. It's not going to be a mandatory equipment that's going to be carried by ACP paramedics. And largely because of the short pre-hospital time when you administer Lasix, although there is some preload reduction initially, mostly it's from the diuretic effect, which doesn't take until at least 30 minutes. So we're just not seeing a lot of Lasix use, and I don't think there's much value in it. So at this point, it's still a patch medication, so if the paramedic wants to patch in for Lasix, they certainly have that option to do that.
There's been one other question about clear sputum versus pink frothy sputum, and is pink frothy sputum a sign that the patient's condition is worsening? This is obviously talking about CHF patients. Personally, I don't think that you can differentiate if someone's getting worse based on the color of their sputum. Pink sputum indicates that there's been an element of blood within the sputum, not necessarily frankomopsis, but blood going across respiratory membranes. But there isn't really an indication that pink is worse than white or clear.
Great, thanks guys. Any other questions out there? All right, any last comments from, oh, actually, there's another question up there.
No, that question's a thank you there, Steph. So.
Oh, thanks, Art. All right, well, sincere thank you to Dr. Luell, Dr. Ducolo, and Morgan, as well to Dave Usage for running a little bit of the background of this webinar. Thank you once again from SWORBH Hospital, and we'll see you again at our next webinar.
Just to add, Stephanie, we also had Tracy Gaunt, our educator from the north of the region, Severa Rodriguez, our program manager / boss, and Dr. Matt Davis at this webinar.
Wonderful. Thank you, everyone, for attending. Have a great day.